This is Blood and Cancer, the official podcast of MDedge Hematology/Oncology, where we discuss the latest research, treatment considerations, and other issues related to hematology and oncology. Welcome to this podcast. I'm your host, Dr. David Henry, and I'm delighted today to be speaking with Dr. Jonathan Tward, who is professor of radiation oncology, leader of the HCI Genitourinary Cancer Center, the Huntsman's Cancer Institute at the University of Utah, a radiation oncologist and specialist in that field, in particular prostate cancer. Jonathan, thank you very much for joining us today.
You're very welcome. What a pleasure it is to speak to you, Dr. Henry, and I'm looking forward to some great discussion.
Well, likewise, and thank you very much. So, as you know, I'm a general hematologist, oncologist dinosaur, I guess by now everybody's highly specialized. And prostate cancer, especially as our population ages healthily, some of our men are developing this, and it's always I'm a medical oncologist, so often the surgeon and the radiation oncologist send the patient to me to break the tie. So I'm happy some of your research is going to help us break the tie. So I thought we get right into it. I'm going to read the title of a presentation you made this year, 2021, at the Genitourinary Cancer Symposium, entitled Association of the Clinical Cell Cycle Risk Score with Metastasis After Radiation Therapy and Identification of Men with Prostate Cancer Who Can Forego Combined Androgen Deprivation Therapy. So maybe if you give us what your idea was, your research was, and what's this score, and then we'll go deeper into it.
As you point out, the prostate cancer patients are often talking to surgeons and radiation oncologists in the localized prostate cancer setting. And, that might account for 85% of newly diagnosed prostate cancer patients. They have localized disease that's likely to be cured. And, the biggest question on the table for a localized prostate cancer man starts off with, should you even treat or not, right? And then,
Yes, right.
And then once the determination of should you treat, that lapses into, what might be the best treatment option for you. Not to say that there's necessarily a best or worst treatment option, but men with prostate cancer have choices. And, conventionally, what we've done to help make those decisions is to use what people now call risk stratification, so-called NCCN risk groups. And these risk groups were really started by Anthony D'Amico when he first published a paper in 1998, where he kind of stratified men into these categories of low risk, intermediate risk, and high risk. And I think that, most people today would say something like men with low risk cancer should be, surveilled, and men with intermediate and high risk localized prostate cancers should get definitive treatment. And I think that the decisions that surgeons make and radiation oncologists make are related, but a little bit different. And, whereas surgeons are generally determining things like surgical approach and nerve sparing and this and that with regard to active treatment, the radiation oncologist is considering, do you or do you not use hormone therapy with radiation? And, should I treat lymph nodes or should I not treat lymph nodes? So kind of different ideas. And again, conventionally, what has guided us to making those decisions about, in the case of radiation oncologists using hormone therapy or not, is going back to this risk group understanding. And right now, the NCCN says that all men with so-called unfavorable intermediate risk radiation or prostate cancer, they should get some hormone therapy, and all men with high risk prostate cancer should get some hormone therapy with radiation. But if you look at those men who are so-called intermediate risk, these are men with Gleason scores of 7, or their PSAs are between 10 and 20. It's really a wide spectrum of actual risk. And so it's hard to know if you're over-treating them or under-treating them.
Mm-hmm.
And these traditional risk groups are actually only based on 3 pieces of information. What is the PSA at diagnosis? What is the Gleason score? And what does the prostate feel like? And, we've had these parameters around now for 30, 40 years. And I think risk groups are reasonably good at prognosticating who may or may not go on to have metastasis, et cetera, but they're not that good.
Mm-hmm.
So a lot's changed, in the last 15, 20 years that can help with really trying to personalize these treatment decisions. For example, people are starting to rely on MRI scans to help, evaluate whether or not someone is better or worse than they thought based on conventional parameters. But finally getting to what is my presentation,
Yeah.
I'm in the risk stratification business. And I think that conventional clinical parameters are very important, such as what is the PSA, how fast is it doubling, what is the Gleason score, etc. But any one of those things is not particularly good at determining aggressiveness. And Gleason score especially is very subjective, right? You can give one pathologist a path report and they might say it's a 3 + 4 = 7. And you can give another pathologist the same specimen and they might say 4 + 3. So there's wiggle room on the interpretation. So I was looking at molecular diagnostics, molecular markers. And it was my theory years ago when I conceived of this study that looking at some of the molecular genetics in concert with the known clinical parameters can give you better risk estimates than what these conventional low risk, intermediate, and high risk do, and can probably help guide therapy. So what the research was taking an off-the-shelf test, which is currently available by Myriad, called the Prolaris test. And what that test has been used for and has been approved for is generally making decisions about surveillance versus not in men with lower risk prostate cancers. But I hypothesized that that same test could be used to help guide radiation oncologists on when they should or shouldn't use hormone therapy. And what it's specifically measuring, and then I promise I won't keep talking so that you can engage in a dialogue.
I'm listening. All right.
Yeah. What that test measures is something called cell cycle progression genes. So what one does is you take the biopsy specimen that's already been obtained, you can send it to Myriad, they micro dissect the cancer cell off the slide, and they look at the expression level of genes that are correlated with how fast cells are going through the cell cycle. And so it wasn't exactly a test that was designed specifically around prostate cancer per se. It was a test that's just looking at how fast are these malignant cells sort of growing and dividing, is how I like to think of it. And they're able to generate a molecular score based on these cell cycle genes. So you now have this molecular information, which is a very objective measure of something. And that measurement alone can be used to prognosticate certain things like risk of metastasis after treatment or risk of dying of cancer if you're on surveillance. But you start taking that molecular information and you combine it with the other clinical variables like the Gleason score, the PSA, the percent positive cords. And so you're combining molecular information with clinical information into an incredibly robust risk model, what I would call a highly personalized risk estimator that can very discreetly tell a man, for your exact prostate cancer, if you have surgery, we think the odds of you developing metastasis in the next 10 years might be 3%, or it might be 15%, or same thing with radiation. For you, sir, exactly, it's going to be either 17% or 5%, etc.
So the surgery versus radiation, I always think in the average patient, when they come to me as the medical oncologist, in the proper hands, they're equivalent. Is that you're still in that belief? So radiation or surgery equals each other?
I think it's fair to say that the ultimate cure probability of a localized prostate cancer patient is equivalence between the two. But I think what people don't fully appreciate is that as your risk goes up, whether you're talking about risk groups or nomograms that predict risk of metastasis, et cetera, the probability that surgery alone is going to be sufficient becomes less probable. So I think if you ask the question about surgery plus or minus radiation if you need it, being equivalent to radiation alone treatments with or without hormone therapies, yes, they're equivalent. But one thing we observed, although it wasn't the primary focus of the studies, is even though we were looking at metastasis and the Prolaris test as helping guide radiation oncologists, it can also be used to predict the likelihood that you develop biochemical failure after surgery and therefore would need, to consider salvage radiation therapy.
Need you anyway, yeah.
Yeah, and it's not to say, currently where urologists are is they're using ultrasensitive PSAs after surgery to sort of guide, that decision. But it would be nice even for the surgeon up front to be able to tell the patient, you, sir, if you go to surgery, have a 20% chance of needing, radiation versus you, sir, will have a 70%. Like even the test in that way is highly personalized in a way that's much more accurate than risk groups would be.
Well, I think what you've done as you're talking, that's reminiscent immediately of the breast cancer doctors. So they use the Oncotype DX. There's a couple of them. That's one that we use most popularly in my center. And it's got 21 genes. It looks at them in the on and off position, develops a score. And it's very somewhat prognostic and predictive. And then most recently, you're probably not living in this world, Dr. Sperano joined that with clinical features, just like you're doing, to generate the RS Clin score, recurrence score clinical, to combine the highly specific objective DNA testing with what your clinicians say about your clinical risk, put them together, and you have some really useful information to talk about with the patients. That's what you've done. In fact, I'm looking at your nice slide, and again, we'll have this in our show notes so listeners can click and take a look from your genitourinary cancer symposium presentation, where it says CCR equals, and there's a nice arithmetic of multiplication times the CAPRA score, which I'll ask you to describe, and the CCP score, your Prolaris score. So you put them together and you get the DNA plus clinical equals risk discussion with the patient. So what's the CAPRA score?
The CAPRA score is a different risk stratification that was developed at UC San Francisco. I believe Dr. Matt Cooperberg developed this scale. And the CAPRA scale is just an alternative risk stratifier that goes from 0 to 10. And higher numbers are higher risk of biochemical. It was originally shown as biochemical failure after localized treatments. What was nice about CAPRA, which uses purely clinical data, it uses your age, your PSA, the percent positive cores, your clinical T stage. It gives you these 10 strata, and each additional point on CAPRA is roughly a doubling of the hazard ratio of a biochemical failure. So CAPRA is kind of an alternative thing to, let's say, NCCN risk groups that I think urologists are quite familiar with, but most radiation oncologists are not familiar with CAPRA. They don't routinely use it. But I view the CAPRA score overall as a very good sort of nomogram to prognosticate certain things with prostate cancer treatment. But again, when you combine that CAPRA risk with the so-called CCP score, which is the cell cycle progression score that we were talking about, that is what Myriad is actually measuring, into this combined CCR score, and I'm sorry for the alphabet soup, which is the combined clinical risk score. That's right. What we're talking about, is using this molecular data and another validated clinical data to get an extremely robust model. An analogy I was thinking of when you were talking about the breast cancer was, if you want to know, the more parameters you build into what I call a risk model, the more probable it is that you'll be able to both accurately and precisely predict something. Like if you wanted to know if it was going to rain in the next 2 hours, you can look out your window, and if you see storm clouds across, the way, you might have a certain idea of what the probability of rain is. But then if you also check the radar, you'll have an increasing, increase. And then if your grandmother's joints ache, it might be an even higher risk. And so it's the same concept. You keep adding things that are known prognosticators to get a much more precise and accurate estimate. And that's what we're doing.
So are you, that leads me to ask, are you using it in clinical practice, or how have others fared using it? And I think I see in my notes you did a poll conducted on how this went on risk reduction and treatment choice. So could you comment on those two?
Yeah, well, it's sort of two separate questions. Do I use it in my clinical practice? So I've been actually using the Prolaris test without strong data until recently to support my biases. So I've been ordering this test on my patients for at least the past 7 or 8 years, across the spectrum of Gleason scores. I was always ordering it in Gleason 6 and 7 patients to try to help with the determination of surveillance or not. And I was using it also in Gleason 7 and 8 patients to try to nuance the question about hormone therapy, although I was doing that without the evidence that I now have. But I have probably run this test just in my own practice on 400 to 500 patients, and it's really, we felt, helped us nuance the treatment. Of course, the study validates very clearly that it does.
Mm-hmm.
But really what I was trying to figure out with the poll that you allude to is the following. It's easy to define statistical significance. And statistical significance is this sort of arbitrary discussion that if you do some kind of statistical test and you think the result is different by no greater than 5% chance, it's, quote, statistically significant. And when you think about oncology, what we actually use, generally speaking, to determine whether intervention A versus intervention B should be recommended, it tends to be based on hazard ratios, right? So if you test drug A versus drug B, and you say that there's, let's say, a survival benefit of drug A, and it's a hazard ratio of 0.66, and the p-value is 0.05, it's significant, that tends to become a care standard. But what gets lost in this discussion of hazard ratio is you first have to determine, and this is something oncology hasn't been very good at, what is the absolute risk of that bad thing happening. So going back to that analogy, and actually this is the perfect analogy for hormone therapy with radiation. There's been numerous randomized trials now that have proven unequivocally that if you add hormone therapy to radiation therapy for localized prostate cancer, your risk of metastasis is going to drop, and the hazard ratio will be about 0.66. In normal speak, that means anyone who gets that combination is 2/3 as likely to, quote, fail as someone who gets radiation alone. But if the absolute risk is only 1% at baseline, then dropping that 1% risk to 2/3 of 1% might not be clinically significant, right? Like a patient facing that question of, should I add in a toxic additional therapy like hormone therapy for 6 months? Yeah, the hazard ratio is 0.66, but if it's a 1% chance to a 2/3 of 1% chance, they might say, no, thank you. So the poll that you allude to is the following. I was trying to figure out what clinician experts and perhaps so-called lay people think is a clinically significant difference. So I asked members of the NRG GU Group Steering Committee, and the NRG is a cooperative group that runs clinical trials across the country in prostate cancer. And so these are the real experts in radiation oncology and urologic oncology who understand all the nuances of these therapies. I asked members of that committee to pretend they were the patient. And let's say they had a localized prostate cancer, and they knew that they were going to get radiation therapy. That was the scenario. And they were trying to determine whether or not they would also accept at least 6 months of hormone therapy with it. At what absolute risk reduction would they have to see in metastasis over the next 10 years to be willing to take that additional treatment? And basically about 80%, 75, 80% of the experts said that absolute risk reduction had to be at least a 5% difference in risk. So in other words, they wouldn't do it unless the risk of metastasis went from 10% down to 5% or greater. And so what the Prolaris test does, the CCR score, what this research shows is it'll give that patient, that individual, that exact number. If you do just radiation alone, it might say your risk of developing metastasis is 12%. But if you combine it with hormone therapy, it'll drop to only 6%. So now you see that absolute risk reduction is 6%. And you can tell that patient, that's a number needed to treat of about 18 people, 17 people. Like you, sir, do you think it's worth 17 people getting this drug unnecessarily for one to benefit? And that's people will answer that differently. But
Mhm.
for the most part, most experts would place that number needed to treat at 20. Most experts would, and so would most lay people.
But I think the nice thing is it gives you hard information to have this discussion. And I couldn't agree more with the, the hazard ratio goes to 0.66, but is that a wonderful hazard ratio of a small number or
Right.
of a large number? What is your absolute benefit? So important as we talk to patients. Well, I wanted to talk about a case that we kicked back and forth before talking to try and bring it on home as to what might happen. And this comes into the office all the time. We'll say a man had a PSA, he's being followed, he's 65, otherwise healthy, followed by his primary care, and PSA is 6, and you were always less than 4, better see the urologist. He does, he gets a biopsy, and he has had prostate adenocarcinoma, and he has on the right side a Gleason 4 plus 3 equals 7, and it's a small amount of one core. And that's at the base and the mid prostate. So again, to our listeners, we cut it up into 3 pieces on each side, so 6. So in the mid right biopsy prostate, it's a 3 plus 7, the reverse, and it's involving about 80%. So 2 questions to you. What's the difference between 4 plus 3 and 3 plus 4? And how would you handle this patient who has each 4, 3, 3, 4, and more on one core than the other? And a 65-year-old is going to live 10, 25 years, we think. And what should he have done?
Yeah, this is a case where it's one of the most high yield places to get a test, such as the one we're talking about, because the way that I think a urologist or a radiation oncologist might think of this case is the following. A Gleason 4 plus 3 equals 7 cancer can potentially behave like a guy with Gleason 8 or 9 cancer. And a guy with a Gleason 3 plus 4 equals 7 cancer can also behave like a 3 plus 3. So there's this wide variability in actual clinical behavior that Gleason 7s, whether they're 3 plus 4 or 4 plus 3, are just sort of hard to interpret. And so a case like this is really an important question of how much therapy is too much therapy. Like, should I think of him as high risk or not? So now what the average clinician does is they start thinking about the other things that you mentioned. He's 65, he has a long life expectancy. But as presented, when they do a normal prostate biopsy, they typically take 12 cores. And in this example, only 3 of the cores were positive. So I think, a urologist or rad onc is thinking this guy has low volume disease. His PSA is only 6, and we like to think of PSAs under 10 as being sort of boring. It's kind of a low risk feature. We can presume that they didn't feel anything weird on the prostate. And so right from the get-go, the treating physicians are kind of wondering, they're probably saying to themselves like, gosh, this kind of is smelling like a low risk cancer. Maybe I could even consider surveillance. But oh, by the way, the rule book says thou shalt not surveil a Gleason 4 plus 3 guy. So you're already, got this line in the sand based on expert consensus guidelines saying you shouldn't do that, even though this guy may have a very low risk of progression on surveillance. And then the radiation oncologist is going to look at this and say, gosh, they gave him a 4 plus 3, which means he's, quote, unfavorable intermediate risk according to the rule book. And according to the rule book, thou shalt give at least 4 months of hormone therapy. But it just smells to me that it's less aggressive. Like I think I can get away with just radiating him, or maybe even possibly
So
surveillance.
you apply your research to this patient.
Yeah, excuse me?
So you apply your research to
I
this
absolutely do.
patient.
So this is a patient. I order that Prolaris test. And first of all, what one would see resulted is you take into account all these clinical factors, the molecular factors, and the score report would very discreetly tell you what is this guy's risk of dying of prostate cancer in the next 10 years if he was surveilled, or really kind of not actively managed right away. And that might be helpful in this case if you really thought that you were going to go along that path. I think most people wouldn't go along the path of surveillance, but it could potentially influence you. But most importantly, I think, given the fact that the vast majority of clinicians would recommend treatment, where this really helps is discriminate what is this guy's chance of metastasis within the next 10 years if he had radiation therapy alone or a surgical therapy alone. And we've actually developed some thresholds to help guide the clinician that say, look, this guy's risk of metastasis isn't high enough to talk about combined modality therapies. Like it should be safe. It's okay for you to just do radiation alone and skip the guideline recommended 4 months of hormone. Or
that's really the key here, is what this test can do for us.
That's exactly correct.
This patient's going to be facing, I like the radiation therapy idea. I know I have to do that ADT, androgen deprivation therapy, but we apply this model and maybe we can avoid, depending on the characteristics of plugging into the model.
That's
and
right.
We'll include this in our show notes. I think we were talking where it's not peer-reviewed, hard published yet, or is it?
So the studies, there were 2 studies that we're talking about. One is the so-called development study that was done in a population of over 700 men, where we sort of, I guess, demonstrated that we thought this test was good in both surgical patients and radiation patients, and determined a threshold that we could test on should you or should you not get multimodality. That's been published. That was published a couple months ago in Clinical Genitourinary Cancer.
Okay.
And that's a nice paper for the urologists also to look at, because it shows the risk of biochemical failure after surgery, and that can help inform the discussion there. But then there's a second paper, completely separate population, the validation study, over 700 patients from about 18 different institutions contributing, where we validated that threshold and the findings from the first one were accurate. And that was what was presented as one of the plenary oral presentations at the GU Cancer Symposium this year in February, and that manuscript is currently under review.
Well, that's wonderful and so helpful. Well, I want to draw it to a close, and thank you for this practical information and this practical test. Again, I'm thinking of the very scientific, like the oncotype and breast cancer, and then the clinical, and putting them together, because it is so difficult as we see these patients. Or how long are you going to live? These are our men with prostate cancer. Is it rising fast? What are the Gleasons? How many cores? And to bring it on to something a little more rigid and scientific is better, certainly for those of us in the clinic who have to discuss. So I want to remind everyone, you've been listening to Dr. Jonathan Tward, who is Professor of Radiation Oncology, leader of the HCI Genitourinary Cancer Center, Huntsman's Cancer Institute at the University of Utah, a radiation oncology specialist. And we have show notes that will be published on the website, mdedge.com/hematology-oncology, to go through what you've just heard, bullet points with the links to sites where you could see this and try it at home with your patients on this particular calculation, which I'm going to use next week. So Jonathan, I want to thank you very much for taking the time to talk to us today.
You're very welcome. What a pleasure it was again to speak to you. And I hope that this gives your listeners actionable clinical information.
Thanks again. Blood and Cancer is produced by MDedge. Our editor is Jen Smith. All MDedge podcasts are produced by executive editor Kathy Scarbeck, and I'm your host, Dr. David Henry.